worked for the NHS as a consultant since 1993. He's a reader in the Department of Diabetes in the London School of Medicine. And his research interest is basically about body weight, consequences of obesity, and the vascular disease with diabetes and hypolipidemia. And he spent some time in his career also at the King's College Hospital, in the Mayo Clinic in the US, and also at Oxford University and UCL Medical School. He even wrote a book about obesity and diabetes, or a chapter of a book in clinical biochemistry, which got over 100 citations. And yeah, we are honored to have you here, and we are very much looking forward to your talk. The way this will be is he will give the talk. Afterwards, we will do a Q&A session. And with this, I'm happy to hand over to Simon, to you, and I will start sharing the slides now. Give me 1 second. Okay, I hope, can you see my slides?
Yeah, we can see them.
Yes, perfect.
Thank you, Martin, and thank you for the invitation. Just by way of background, these I've as well as working in the NHS, I've been teaching about obesity to medical students and junior doctors for a good while, and I guess a lot of these slides are based on what I've been saying to them. If I could have the first slide, please, Martin, or the next slide, perhaps. I've got a lovely picture of your face, but not of the slides.
I can see them on my end.
Okay.
Yes.
They're extremely small. Okay, yeah, right. Okay, so if I can start extremely broadly, I think what I would say is that obesity is the topic today, but the difficulty is that it's linked in with a lot of other related problems. Perhaps the worst one from the medical point of view is it's almost impossible to distinguish obesity with low physical fitness and low physical activity, because the two are extremely highly correlated. And then to make things even more complicated, there's a sort of reciprocal relationship with other medical conditions, or issues, I should say. So first of all, there's the relationship with the fitness itself, but it then also has impacts on psychological issues. It causes musculoskeletal problems, and also on a sort of social aspect, it has quite profound social implications. So all of these impact on what you can ask a patient to do, or someone who's interested in addressing their body weight. So I think although obesity is at one level simple, and people tend to think of it as a single factor, that isn't what really happens in the real world. It's deeply tied in with multiple other issues. Next slide, please. Now, obesity is in many senses quite unusual. It's something that almost every patient knows they've got. It's something that almost every relative knows a patient's got, or someone's got. You could argue it's the most easily recognized of medical conditions. I don't want to be too critical of the WHO, but because the WHO has, for good reasons, used the body mass index, which I'm sure you've all heard of, which is also called BMI, and that's just the weight divided by the height squared. Sorry, that's a mistake. Which is their standard. The bad news is it's not a perfect measure. I'll show you some data on that in a minute. But I think the importance of that really is that if you actually used a better measure than BMI, so for example, if you use adiposity, a better measure of adiposity, most of these correlations that I'm going to talk about would get even stronger. So the fact that we're using this rather imperfect index actually weakens the strength of what we're seeing. Next slide, please. This gentleman, the WHO thinks is obese. He's got a BMI of 33. And although he may have got some medical problems and maybe even some psychological problems, obesity is certainly not fat. This is his percentage body fat, which is extraordinarily low. I'm not sure that we all look at Muscle Mag International every day, but there are people like this. But he's a nice example of how the BMI just lets you down when you're faced with people with more muscle than you might expect. And the next slide, please. This is a slightly more sensible look at that issue. And on the x-axis, you've got the body mass index here, and you can see they've gone from people that are quite... oh, sorry, can you see my pointer?
No, we can't, but we
No.
can see the plot.
Oh, where's my...
I can point.
Okay, well, you can see that on the x-axis, the BMIs are going down from sort of 15 right the way up to, which is pretty damn skinny, all the way up to, thank you, to 50, which is pretty damn plump. But even if you look at sort of what you might call healthy BMIs, between in the low 20s, you can see that the percentage body fat, well, first of all, you should notice that the ladies are all on a different curve from the men, and it shouldn't come as any surprise that ladies are more cuddly and than blokes who have a higher muscle mass. So the percentage of body fat is always greater in ladies. But if you just look at within those yellow squares at, say, a BMI of about 20, you can see that some ladies have got a BMI, percentage body fat at about down at in the high teens, and some are way up in the mid 40s. So even with a BMI which is healthy, you can end up with people with really good low levels of adiposity, and people who are really carrying more than you might advise. So this just goes to so I think the main evidence is really that BMI, although it's a good index, it's not perfect. Next slide, please. If we look at, as Martin was saying, I mean, my background is very much a medical one. So to some extent, I think primarily of what you might call the medical issues related to obesity. And this is a version of a fairly busy slide, which sort of just lists all of these problems that go with obesity. And if you're just going anti-clockwise, starting in the top left, you'll see lung problems, and then you start to see liver problems, gallbladder problems, gynecological problems, arthritis, which is actually a huge problem. It's just a single word. You've got the problems with skin and more joint problems. Carrying on round, you've got problems with veins, and then you go up to cancer. I'll talk about that a little bit more in a minute. Going up to the sort of 3 o'clock position, you've got pancreatitis, and perhaps more importantly, heart disease and diabetes, which this is the main reasons where most of the excess mortality comes from the coronary heart disease and the diabetes. And at the top, you've got some further problems like strokes and intracranial hypertension. And this slide, busy though it is, didn't mention the kidney problems. So I've written them in yellow, and didn't even mention the psychological issues, and there's others as well. But just to sort of say that this is there's a large number of problems that follow from being overweight. Next slide, please. And I think you could argue that obesity has a greater impact on ladies than it does on blokes. And I would say that first of all, the psychosocial impact is greater. And I mean, I know we're all in different countries, but how many slimming magazines are there? Anybody ever looked at a magazine rack and looked at how many slimming magazines you would see in most newsagents or supermarkets?
Probably a lot.
Yeah, I mean, I'd be pretty shocked if you don't see 3, and in some places you might see 5, 6 or 9 different magazines. And I would argue that actually none of them are targeted at men. I mean, actually some men's health magazines do cover it, but overwhelmingly the social impact and the social interest is on ladies. I'll show a little bit of data on the cancer effects, and we'll just quickly touch on some fertility issues as well. Perhaps the next slide, please. In terms of the psychosocial, depression is probably one of the big issues. Some people say anxiety is an even bigger issue, but perhaps the data is more clear-cut on depression. And if I may, I would suggest that, well, the bullet points here say that depression is very common in obesity. And when you do longitudinal studies to see which comes first, the obesity or the depression, there's no doubt that people who get heavy, as they get heavier and heavier, depression follows. But you can also see people who started light with depression, they generally go to a lot of studies show they're predisposed to get to obesity. So this causality seems to go in both directions. I've pulled up this particular study which tried to look at the relative frequency of how well obesity was related to depression in men and women, or perhaps I should say it the way around. Actually, it's how depression relates to obesity, and you'll see that the relationship between depression and obesity was much stronger in the ladies than it was in the men, and you can see that they've done a fairly careful way of looking at this. They've used the BMI, but they've used the body fat and the visceral body fat and all that. And you can see that they came to, it wasn't a huge study, but it was pretty clear that the relationship was strong in ladies and wasn't visible at all in men. So this relationship is much more, has much more impact on ladies. Interestingly, if the longitudinal studies show that obesity can lead to depression, then treating obesity can actually stop depression, and that's the last bullet point down there, where if you get about half the people lose their depression if they lose weight through bariatric surgery. Next slide, please. Cancer, cancer. I think it's becoming increasingly recognised that obesity is a big driver to cancer. This is a recent overview, and they said 21% of American cancers could be attributed to people having a BMI greater than you would wish. Worldwide, it's a little bit more messy, because worldwide there's a lot of thin people, and smoking rates are higher in some parts of Asia, and smoking is the biggest modifiable disease. But in Western Europe and the US of A, where smoking rates are less and obesity is worse, obesity is the biggest single modifiable risk factor. So overall, obesity is now driving more cancer than anything else in our environment, radiation, smoking, anything else that you might wish to mention. Again, you can't, it's very difficult to distinguish obesity from poor physical fitness, but it's that constellation that's now causing most of the cancer. Next slide, please. And again, I would argue that this weight falls more heavily on ladies. This is a slightly complicated slide, for which I apologise. On the left column, you'll see a list of cancers, and you can see that in the second column, this is a meta-analysis. There's lots of studies against each different cancer. So there's 19 endometrial cancer studies, 4 studies of gallbladder cancer. And then the third column is the relative risk in ladies of being overweight, and the last column is the relative risk in men of being overweight. And you can see that there's some fairly worrying increased relative risks from being overweight. It's driving a lot of endometrial cancer, a lot of gallbladder cancer coming down. It's causing more breast cancer, ovarian cancer, and stomach cancer, and that's really having more. So it's having more impact on it's more of a driver to cancer in ladies than it is in men. It is. I'm not saying it's not a factor in men, but if anything, it's even more problematic in ladies. Next slide, please. I think that you guys are going to talk a little bit about pregnancy, and so I thought I was asked to. I'm just quickly touching on that. I need to just briefly define some terms. So you've got macrosomia, low birth weight, gestational diabetes, and hypertensive disease of pregnancy, which are all vague. There's a couple of words about each of those there. And the study I'm going to highlight is this one. And what they've done is they've looked at these outcomes in relation to people's body weight, and they've done some corrections, and how they've corrected is the basis of their models. They're different models, which are in the next slide. I don't think there's anything crucial about these models. It's just to say they're all very sensible adjustments, and this is the data. Here you've got those outcomes in the left column: macrosomia, low birth weight, gestational diabetes, and hypertensive disease. This is the odds ratio comparing people to a healthy weight, and here you've got to ladies to so these are the underweight ladies in the third column, and the overweight ladies in the fourth column. And you can see that macrosomia is much commoner. Well, macrosomia doesn't happen in underweight ladies. It is driven by being overweight. Low birth weight is driven by both being underweight or overweight, more so underweight. But when it comes to diabetes and the hypertensive problems, again, they're much more driven by the obesity, and as you saw, they've done nice corrections. So they've corrected for age and parity and social class as best they can. So to some extent, these are real biological factors, suggesting it's the biological risk of being heavy rather than being having had a lot of babies or being older. So there's pretty strong evidence that gestational diabetes and hypertensive disease of pregnancy are both big problems driven by being overweight. Next slide, please. I haven't got as much time as I'd like, but I'm going to quickly run through this issue. Because the real problem is, if everybody can spot this problem and everybody knows it's important, why isn't it dealt with? And I think the thing is that we underestimate how difficult it is for people to lose weight. I think people can lose weight, but they can't lose as much as they want, and they certainly can't lose it as fast as they want. It's difficult to maintain, and it's because of these problems that we end up with thinking about drugs and bariatric surgery. Next slide, please. They're a little bit old, but they're actually current opinions are just as extraordinary. This is what happens when you ask patients how much they want to lose weight. If they start at so this is about 100 kilos. So these are big people, particularly for ladies, and you ask them how much they'd like to lose, and they're looking for these sorts of percentage reductions. The difficulty is that 17% is probably what you get from one of the new, what you might typically expect from one of the new GLP-1 drugs. 38% is a good result from bariatric surgery. So these are extraordinary results to achieve by non-drug or surgical interventions. So the big problem is that patients have got what I would call, I've called it unrealistic, but they're certainly ambitious targets. Next slide, please. Can I just ask, can I ask the audience, what do they think is a suitable rate of weight loss? If you were going to lose weight, what do you think people should be, what would you expect people to be aiming for, either from personal experience or from what they've seen other people aim for? How quickly do you expect people to lose weight?
think this depends on the starting point, I assume.
Okay, well, if we go back to the starting point on the previous study was at 100 kilos. Let's start with something on that. And for a lady of 100 kilos, because this study was done in ladies actually. So if you had a lady of 100 kilos, which I guess, so for a bloke that would probably, for a tall chap, that's probably about 140 kilos or something in that order. What sort of, if you're a lady with 100 kilos or a chap with, actually perhaps that's probably a bit unfair, a chap at 125, what sort of weight loss would you be, what speed of weight loss would you be aiming for?
I can just read out the options in the chat. So we've had 1.5 kilograms per month, 5 kilograms per month, 1 to 2 kilograms per week, 1 kilogram a week, 3 kilograms a month. Those kind of figures.
Okay, and those are actually, thank you. And can we just go forward a couple of slides? Now those are so I think that even amongst this this very educated audience, I think everybody's overshot. Is that right, Bryony? Because the normal, although you can lose more in the first couple of weeks, the usual recommendation of people on a sort of slow and steady weight loss, well, a steady weight loss, perhaps not slow, is that you aim for about minus 500 kilocalories a day. And that means a net energy balance, that's giving you a net energy balance of about minus 25%. And that equates to about half a kilo a week, which I think is lower than any of those offers that you had. If you actually look at what happens in medically supervised studies, actually people deliver about 1/4 of a kilo a week, which is comfortably under the ambitions that people were expecting in this, as I say, generally educated audience, and certainly more than most real patients do. And to some extent, of course, you can see the logic. If you're 100 kilos and you want to lose 10 kilos or maybe even more, and what you're going to do is losing you 1/4 of a kilo a week, that means that you're faced with a prolonged period of having to stick to your diet and exercise program, and you're not going to see much. You're not going to see the much improvement immediate. Well, you may see a bit in the first couple of weeks, but after that, it's going to be depressingly slow for most people. Next slide, please. This is an example of that you also need to be careful. This is a short-term study. They didn't lose a huge amount of weight, but what they've got here is 2 different versions of the study. The first one is basically the black bars, and you'll see that they are losing nearly 2 kilos in these few weeks. But they've also broken it down into how much fat they've lost and how much muscle they've lost, effectively muscle they've lost. And you'll see that with diet alone, they lost a bit of weight, but none of it was fat. It was all muscle. In fact, you could argue that this diet alone has actually been counterproductive, because these people have just now made their body composition worse. They've now they've probably got a higher percentage of body fat at the end of the diet than they did at the start. So this emphasizes that quick fixes like crash diets can actually be counterproductive in terms of losing the wrong sort of tissue. Next slide, please. I do wish I had more time for this. This is a really interesting study. These are men done just after the war. They were conscientious objectors, all extremely motivated. They were mostly, highly religious people and wanted to do something but didn't want to go and fight. So they volunteered for a study which was to help scientists understand starvation, because at the end of the Second World War there was mass starvation in different parts of the world. So these conscientious objectors, these religious volunteers, were very keen to help, and they were asked to go on an 1800 kilocalorie diet and walk. They ended up losing about 1 kilo a week. Next slide, please. And they really reported awful symptoms. I probably haven't got time to read all of that, but if you just look at this, these people really just couldn't face this, even though they were extremely motivated. Yeah, I mean, if you look, yeah, they were just wrecked by it. Next slide, please. That's their psychological, how they felt. This is what actually happened of the biological things. Their physical endurance, they just couldn't move very well. Their physical strength dropped markedly. Their metabolic rate dropped dramatically. They started feeling terrible. They started sleeping more. Again, they were just not able to function. So this is the consequence of over starvation, which is really why it becomes so difficult for people to go on crash diets. If you go on commercial crash diets, I don't know whether you've heard of things like Slim Fast or the Cambridge diet. They often get people into this sort of situation. You can lose weight very fast and end up feeling awful at the end of it. Next slide, please.
Simon, just to say, we've got a couple minutes left, so I don't know if we want to just close up and move to questions maybe, and we can also share the slides with people. Does that sound okay?
I think I've only got a couple left.
Brilliant.
So
okay.
I think, first of all, to say that after that study, these people didn't recover until 9 months, and it's not, although that's one example, the same thing happened when people were put in this, I don't know, this biosphere study. Anyway, next slide, please. Again, a slide I haven't really got time to read through, but this is another thing which says that if a lady, or this example here is ladies, because again they've been more studied. If ladies lose weight, it unstabilizes their relationship. Here's an example of a lady who fell out with her husband, and here's something talking about the increased divorce rate after people have successfully lost weight. Next slide, please. This is just to say that food manufacturers do not help when it comes to people making good food choices. Obviously, these two don't necessarily need to worry about their weight, but you can see that I think it suggests that the Haagen-Dazs ice cream provides more than just a nice taste in the mouth. Next slide, please. Okay, so I want to just finish with saying that obesity is a complex problem. I think it's got biological aspects, physiological aspects, and social aspects. And I would argue that you can make it's not that difficult to suggest that it impacts ladies more severely. I think that's my last slide.
Perfect. Thank you very much. Maybe we have time for one question, because we are unfortunately running out.
I'm sorry, I do apologize.
No worries. I just close this. If there are any questions, otherwise, people got already inspired by your talk so much that they can hopefully find very good solutions for this problem at our hackathon. Let's have a look.
The question, if we have time for one question.
Maybe one quick one.
Yeah, well, first, thank you so much. It was super interesting to hear this talk. I was just wondering if the weight loss is different depending on how long have you been working to lose weight, and depending on the starting weight, and also if it's different for pregnant women.
So the main thing that affects what sort of weight loss you have is how much exercise you do. So as you could see, if you rely more on under eating, then you tend to lose more muscle, whereas if you try to maintain your exercise and do a lot of exercise, then you can maintain the muscle and lose purely fat, which tends to be slower, but it is better for you in the long run. In terms of pregnant ladies, that's really problematic because most people are very reluctant to advocate a strict diet during pregnancy because of the nutritional consequences in terms of people getting problems with vitamins and micronutrients, and most ladies as they get heavier, get further on in the pregnancy, their motivation to exercise drops off dramatically, and indeed their ability to exercise drops off dramatically. So losing weight in pregnancy is, you normally think, oh my goodness, we've left this too late, and losing weight in pregnancy is not the aim. What you're normally doing there is you're trying to stop excess weight gain. So there's I haven't got the slide, but if you look at it more, if you start heavy, you tend to gain even more weight during the pregnancy, and the best you're trying to do in pregnancy is to limit the weight gain. So it's not quite a question of losing weight there, it's a question of gaining less, if that makes sense.
Yeah, thank you so much. Thank you.
Perfect. Since we are running out of time, I want to say thank you to Simon once again for his very nice talk, giving us a very good insight into the research of obesity. And to all the participants, looking forward to hear your solutions, and then seeing you on Friday